Hello and welcome, everyone. Thank you for joining us for today's webinar, TSH-Receptor Antibodies, Nomenclature, Functionality, and Assay Comparison, presented by Dr. George Kahaly, Professor of Medicine and Endocrinology and Metabolism, Johannes, Gutenberg University Medical Center, Mainz, Germany. I'm Christy Jewell of LabRoots, and I'll be your moderator for today's event. We're delighted to bring you this educational web seminar presented by LabRoots. LabRoots is a leading scientific social networking website and producer of educational virtual events and webinars. It is sponsored by Quidel. To learn more about our sponsor, please visit quidel.com. Now, before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want during the presentation. Simply click on the Ask a Question box located on the far left of your screen, type your questions into the drop-down box, and click Send. Our speaker will respond to your questions via email following the presentation. If you have trouble seeing or hearing the presentation, please click on the Ask a Question box to let us know you are experiencing a problem. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located on the top right corner of the presentation window and follow the process to obtain your credits. Our speaker today is Dr. George Kahaly. Dr. Kahaly currently holds the rank of Professor of Medicine and Endocrinology and Metabolism and is Chief of the Endocrine Outpatient Clinic at the Johannes Gutenberg University Medical Center, Mainz, Germany. Dr. Kahaly directs the Endocrine Research Laboratory and has authored more than 160 original papers covering both clinical and experimental aspects of endocrine autoimmunity, immunogenetics of thyroid and polyglandular autoimmunity, as well as cardiovascular involvement of metabolic disorders. He organized and co-chaired numerous international scientific meetings dealing with molecular and endocrine autoimmunity. For a complete biography on our speaker, please visit the Biography tab at the top of your screen. Now, without further ado, please join me in welcoming Dr. Kahaly. I will now turn the presentation over to him.
My name is George Kahaly. I'm a physician working at the Johannes Gutenberg University Medical Center, Mainz, Germany. And I have the pleasure to introduce you to the topic TSH-Receptor Antibodies, Nomenclature, Functionality, and Assay Comparison. Now, this is my disclosure. To start with the topic TSH-Receptor Antibody, I have to go a step back, showing you actually the cause of hypothyroidism, which is induced by the stimulation of the thyroid gland by thyroid-stimulating antibodies. These antibodies are produced within the thyroid glands. They lead to stimulation of the thyroid cells, leading to an increased release of thyroid-related hormone like T3 and T4, causing hypothyroidism. Now, if you have an increased T3 and T4, this will suppress the pituitary release of TSH, which is a hormone produced by the pituitary. Now, the classical phenotype of hypothyroidism is an increased T3 level, an increased T4 levels with a suppressed or low TSH serum level. The cause of hypothyroidism is mainly due to an increased serum level of stimulating antibodies. These antibodies are called TSH receptor antibodies because they are binding to the extracellular domain of the TSH receptor, which is the primary autoantigens in grave disease, and which is a glycoprotein hormone receptor. So these TSH receptor antibodies are specific for the disease, binding actually on the surface of the thyroid cells. The clinical relevance of TSH receptor antibody has been emphasized within the ATA guidelines published recently in the year 2016. And the first recommendation of these guidelines is to go for the measurement of TSH receptor antibodies, telling you that this is warranted for diagnosis of thyrotoxicosis, and other alternative diagnostic steps or ultrasound of the thyroid gland or radioiodine uptake. But clearly, measurement of the TSH receptor antibody is the clue to diagnose Graves' disease. Now, these guidelines not only affirm the use of TSH receptor antibody in the diagnosis of Graves' disease, these guidelines go one step further in the clinical use of the TSH receptor antibody in monitoring or remission, monitoring for remission or for relapse. As antithyroid drug therapy becomes more widespread in the treatment of Graves' disease and or hypothyroidism, the use of the TSH receptor antibodies become paramount in disease management. Now, these TSH receptor antibodies are not only useful to diagnose Graves' disease, and this is the clinical phenotype of a patient with Graves' disease with diffuse goiter. These antibodies are produced within the thyroid glands, leading to stimulation of the thyroid cells. These TSH receptor antibodies are also relevant to actually diagnose patients with Hashimoto thyroiditis, since we are differentiating between different functional autoantibodies. They may stimulate the thyroid, but they may also block the thyroid gland, leading to hypothyroidism and or destruction of the thyroid cells, and the phenotype is well known and defined as Hashimoto thyroiditis. Now, how can we measure these TSH receptor antibodies? We do have two actually assays. The one is the binding, the so-called binding assay. It's a commercially available assay. It's a competitive binding immunoassay defined as TRAB, or abbreviated as TRAB, TSH receptor antibody, or TBII, thyroid binding inhibiting immunoglobulins. This assay measures the total anti-TSH receptor binding activity, but this assay do not discriminate the functional type. As an alternative, and in contrast, the cell-based bioassay is usually dealing with transfected cell lines, using these transfected cell lines with the TSH receptor reporter gene, and with the help of this bioassays, we can both measure the specific stimulating antibodies, abbreviated thyroid stimulating immunoglobulins, or thyroid stimulating antibodies. Also, and this holds true, with the blocking antibody assay, we are measuring the specific TBI, or thyroid blocking immunoglobulin, and or the thyroid blocking antibodies. Now, this might be confusing, and currently many actually abbreviations are being used. For example, TSAb for the TSH receptor stimulating antibody, or TSI for the TSH receptor stimulating immunoglobulins, or TBAB for TSH receptor blocking antibodies, or TSB antibody, thyroid stimulating blocking antibody, or thyroid receptor blocking antibody. Also, the abbreviation TR-Ab for thyroid stimulating blocking antibodies, and finally the TBI, TSH receptor blocking immunoglobulins. While the abbreviation TBII clearly defined the TSH receptor binding inhibitory immunoglobulins, it is a competitive binding assay. So you have to really to clarify the nomenclature and to differentiate between all these abbreviations. For clarity, I will always talk about TSAb or TSI when talking about stimulatory antibodies, and I will talk about TBAB when I'm talking about blocking antibodies. I will use, for also to avoid confusion, the word TBII. I will talk about TRAB, which means the binding assay, the assay not differentiating between the different functional antibodies. Indeed, if you have a sample which is positive for the binding assay, for the conventional commercial assay, these samples can be 100% stimulatory antibody positive, or 100% blocking antibody positive, called TSAb, or you may have a mixture of stimulating and blocking antibodies, or a mixture between so-called blocking and neutral antibodies, or stimulating and blocking antibodies. So to make it clear, only the bioassay exclusively differentiate between the TSH receptor antibody activity, not the binding assay. The binding assay is just telling you that you are dealing with the binding of the antibody in the serum to the TSH receptor to the surface of the thyroid cell. So what is actually the diagnostic utility of this TSH receptor stimulating antibody with the bioassay? It yields and shows the highest sensitivity and the highest specificity according to several randomized trials, prospective trials, showing you also the superiority of this test in contrast to the binding antibodies with lower specificity and lower sensitivity, and also in comparison to thyroid ultrasound, which is a morphological investigation of the thyroid gland. It is a sensitive issue, but it is not a specific test. Also, and finally, the much more expensive radioiodine uptake or scanning, which is really expensive, time-consuming, will give you also less specificity and less sensitivity than the TSH receptor stimulating antibody bioassay. We can use this bioassay or the results of the TSH receptor stimulating antibodies if you want to rapidly diagnose thyrotoxicosis, mainly autoantibody-induced Graves' hypothyroidism. If you have a low TSH, as I have explained before, as shown before in my diagram, telling you that if you are dealing with a suppressed or low TSH, you have to go for the measurement of stimulating antibodies. If these antibodies are positive, they will tell you the true story that you are dealing with Graves' hypothyroidism, while if these stimulating antibodies are negative, you are dealing with other causes of thyrotoxicosis, for example, toxic nodules or autoimmune or subacute thyroiditis. If your TSH is normal, then you are not dealing with Graves' hypothyroidism, you are just dealing with euthyroid subjects, healthy subjects who are thyroid healthy persons not having autoimmune hypothyroidism. A rapid flow chart to diagnose thyrotoxicosis and to differentiate between Graves' hypothyroidism and other causes of thyrotoxicosis. Also from the financial and economic point of view, if you are using the stimulatory antibody assay, this has an impact on the cost of Graves' hypothyroidism and diagnosis. You are reducing the number of thyroid uptake and scan costs. You are reducing the endocrinologist office visit numbers. And more specifically, you are reducing the total payer cost of Graves' disease diagnosis, including the direct cost and the misdiagnosis cost. And you are also reducing the average time to diagnosis by nearly 50%. So just using this test will facilitate diagnosis, will save time and money by nearly 50%. Even more important than the financial issue is actually the consequence of the circulation of this stimulatory antibody in the body, leading to a systemic disease called the systemic autoimmune Graves' disease, showing extrathyroidal manifestation. The disease starts within the thyroid, but you may observe in 50% of the cases patients with extrathyroidal manifestation, proptosis, swelling of the lids, and also erythema of the lids. Also, these patients have so-called pretibial myxedema with the position and accumulation of mucopolysaccharides within the pretibial space, within the legs. And you may also have the same phenomenon with swelling of the fingers, because these chondrocytes and these fibrocytes, fibroblasts, skin cells, thyroid cells, and skin target cells are all expressing the TSH receptor. The autoantigens and the circulating antibodies are causing the systemic disorders. We do observe extrathyroidal manifestation within the eye in 50% of the cases observed. We do observe prediabetal myxedema in 5% of the cases, and in 1 to 2% we do see the swelling of the fingers called acropathy. Is this related with the titer or with the concentration of the TSH receptor antibody? No doubt about it, and this has been shown several times. If you are looking at patients with severe heart disease called Graves' orbitopathy, their serum levels of thyroid-stimulating antibody is significantly higher than those with thyroidal disease only, abbreviated Graves' disease. So patients with Graves' disease and Graves' eye disease show the highest levels. So these antibodies may be regarded as a biomarker of the thyroid disease of Graves' thyroidal and orbital disease. And this is not the case if you are now looking at so-called conventional assay, the TSAb assay. They cannot differentiate between patients with orbital disease and patients with thyroidal disease. No significant differences are observed, showing you the sensitivity of the Bio-assay regarding the differential diagnosis of patients with systemic Graves' disease. And this is also observed in patients, not only in adults, but also in children. This is a child, 8 years old. This is how she looked like at the age of 6. And when she came to our institution with Graves' hypothyroidism, apoptosis, exophthalmos, the lady has a very high titer. This young lady had a very high titer of TSH receptor stimulating antibody. So even children are showing these abnormalities, and we are using the Bio-assay and the measurement of stimulatory antibody both in adults as well as in children. Now, there is also a problem with these antibodies because they are crossing the placenta during pregnancy. This is a lady, she had Graves' disease, Graves' hypothyroidism. We have been treating this lady for 2 years. She became euthyroid. She was doing well, and she became pregnant. And unfortunately, the OB gynecologist did not control the TSH receptor antibody during pregnancy. And this lady developed actually TSH receptor antibody, and these antibody crossed the placenta, causing the neonatal, fetal, and neonatal Graves' hypothyroidism. This is a severe condition which has to be treated. And these antibodies survive in the fetus or in the child for at least 3 months, meaning that the child has Graves' hypothyroidism within the first 3 or 4 months of his life. These antibodies will disappear subsequently, and the lady on the right panel is now 5 years old. This young child developed normally. Her cognitive function is normal, but the most important problem is actually during pregnancy, where the antibody, these stimulating antibody, cross the placenta. So during pregnancy, we are dealing with a problem with the risk for fetus with a history of patients with autoimmune thyroid disease. All female with a history of autoimmune thyroid disease should be checked for TSH receptor antibody. If they have TSH receptor antibody, they can cross the placenta, and these ladies can produce stimulatory antibody, TSAb, and blocking antibody. Both antibody are crossing the placenta and causing problems. There is indeed a risk for fetal infant hyper and hypothyroidism, which correlate with the serum levels of the stimulatory and/or blocking antibodies in the mother blood. This is why measurement of these antibodies during pregnancy is warranted. This is a severe case of neonatal thyrotoxicosis. Surprisingly, the mother was severely hypothyroid. You couldn't imagine that this hypothyroid mother, who was on levothyroxine, on high dose of T4 tablets, could deliver a child with severe hypothyrotoxicosis, severe hypothyroidism, and severe thyrotoxicosis. This thyrotoxicosis already started during pregnancy. The mother was producing all the hypothyroid stimulating antibody, and this led to a very severe case of neonatal thyrotoxicosis with a shocked infant. This child had to be treated on the intensive care units for a couple of days. This child was born with asphyxia, tachycardia, pulmonary hypertension, and cardiac insufficiency. And we have measured the titer of TSH receptor stimulating antibody during pregnancy in the mother blood, as well as in the neonatal and the child's blood after delivery. And all samples were highly positive for stimulating antibody, giving us the whole story that this mother who was hypothyroid was now switching from blocking antibody to stimulatory antibody, leading to hypothyroidism in the newborn. We can also observe another story. This lady was hypothyroid, has been treated for 2 years also for Graves' disease, a very intelligent lady. She left our institution, unfortunately, became pregnant. During pregnancy, the same story. The physician, the GP, and the gynecologist did not look at the titer, at the presence of thyroid-stimulating or blocking antibody during pregnancy. She developed, although she had Graves' disease and was hypothyroid, she developed blocking antibodies. And these blocking functional antibodies blocked the development of the thyroid gland during pregnancy, inhibiting the development of the thyroid gland. These twins were born without thyroid gland at delivery, with severe cognitive impairment, a very low IQ, and unfortunately, these twins have now severe epilepsy. So a clear case of malpractice against emphasizing the clinical relevance of measuring stimulating and blocking antibodies, functional antibodies, during pregnancy. I would go further and say if you are planning pregnancy, it's very important to measure these antibodies prior, during, and after pregnancy, just to be on the safe side. If the antibody titers are high, then you should go also for management of this lady during pregnancy and look at her child or children. So what are we dealing with? We are dealing with a simple bioassay. The principle is that we are dealing with a cell, with a thyroid cell bearing a chimeric TSH receptor. After binding of these antibodies, of the thyroid-stimulating antibody to the TSH receptor, to its ligand, we have an increase of the second messenger, the cyclic AMP, and stimulation of the CRAB pathways within the nucleus, and subsequent release of the luciferase outside the cell, and we can clearly measure the luciferase release with an ELISA reader. This needs an incubation of the cells for 3 hours with the antibodies and leading to increased transcription of the luciferase genes. This is a very simple method, and we are measuring in this test the specimen to reference ratio. The specimen is the sample, and the reference standard is the bovine TSH. This assay has been tested numerous times. We have tested this assay within prospective trial, randomized trial. This has been validated also in our laboratory, clearly showing you the high sensitivity and specificity of this assay. One of the first validation of this bioassay has been published already 8 to 9 years ago. When looking at a large number of untreated patients with Graves' hypothyroidism, we did observe in the majority of the cases very high serum levels of TSI or thyroid-stimulating immunoglobulins. While if you treat the patients with antithyroid drugs, these titers are decreasing, and you are looking now at the second panels in blue, and you may observe that we can significantly decrease the levels of these stimulating antibodies in patients who have been treated. In contrast, if we look at controls, the far right of this diagram, all serum levels of control patients were negative. Patients with thyroid nodules were also negative. Patients with non-thyroidal autoimmune diseases were also negative for the assay, and patients with Hashimoto thyroiditis also. So we had a very high sensitivity and very high specificity of this test. If we go for a cutoff of 140%, we are reaching a very high sensitivity of 99% area of the curve, looking at this SRR specimen reference to a ratio of 140%. This is the typical ROC curve showing you actually the excellent sensitivity and specificity of this test. I will go a further step and say that if you are measuring the serum titer of these stimulatory antibody, you are predicting actually the course of the disease. And this has been shown when looking at a very large number of patients with autoimmune thyroid disease. More than 1,000 patients, consecutive unselected patients with autoimmune thyroid disease, were at our institution. And looking at the first measurement of thyroid-stimulating antibody, we could predict the course of Graves' disease, the severity of Graves' hypothyroidism, and also the risk the risk of developing systemic disease, extrathyroidal manifestation. And as you may see in the upper panel, the odds ratio is 79%. If you go for quantitative TSAb measurement, if you go for qualitative TSAb measurement, meaning if the test is positive or no, the qualitative issue will even give you an odds ratio of 26. So you may indeed predict the course, the severity, the chance of remission if you are measuring at the first time the titer and the concentration of these stimulatory antibody at the first visit of the patients. We are able, with this assay, to transfer or to convert the SRR values in international units per liter to better controls and compare the results of this bioassay with other conventional binding assay. Since all conventional binding assays are showing the results in international unit per liter, we can convert the SRR percent results in international unit using a linear range. Now, the question is, can we use the measurement of these TSH receptor antibody in the treatment of patients with Graves' disease? In Europe, all patients with Graves' disease are being treated with antithyroid drug. And this medical therapy is effective in nearly 60% of the cases. It is becoming more popular in the United States, and more endocrinologists, thyroid specialists are using antithyroid drugs to treat their patients with Graves' hypothyroidism. So our question is, can TSAb help predict the following? Who will respond or relapse to antithyroid drug treatment? How long should we treat? When to stop treatment? And can treatment be stopped if a patient is euthyroid but TSAb positive? Trying to answer all these questions, we did design a prospective trials looking at patients, at a large group of patients with untreated Graves' hypothyroidism, following them for years at least 2 years, giving them for 24 months antithyroid drugs, methimazole with a dosage of 10 to 30 milligrams per day as a starting dose, and serially controlling and monitoring the titer of TSAb at 4 weeks, at 8 weeks, 12, 24, and so on, stopping the drug at 24 weeks and following them for at least, meanwhile, 2 years. If you look at these patients, this is the classical dropout. This is the classical course of the concentration of these antibody during antithyroid drug treatment with methimazole. Usually, we observe a normalization after 6 months of the TSAb titer, but not all patients will become negative. We may observe sustained TSAb positivity for at least 1 year or 18 months. So it's very important to continue and serially measure, monitor the antibody concentration at each visit of the patients. If we do this, we do observe also another important phenomenon, a very relevant and clinically relevant and important phenomenon, which is the possible shift from the stimulatory antibody shown here in green and the appearance at week 36 of the blocking antibodies. And the appearance of the blocking antibody will impact the course of the disease. If the blocking antibodies are present, you will have a very high chance of remission. The patients are going into euthyroidism. You don't need any tablets anymore. This is the optimal time to to stop antithyroid drug treatment, because the blocking antibody are somehow neutralizing the effect of the stimulating antibody. So this is very useful, this is relevant, and this impacts the course of Graves' hypothyroidism. Indeed, we do observe in patients with Graves' hypothyroidism at the beginning TSI positivity or TSAb. The TBI are usually negative. And if we also measure the samples with a binding assay, so-called TRAB assay, we do observe a positive test for the TRAB assay, meaning that we are dealing with binding antibodies in patients with Graves' hypothyroidism. If we continue and follow the patients, and these patients are developing blocking antibodies, and the TSI are disappearing, this correlates with a change of thyroid function. At the beginning, they were hypothyroid, as shown here in green. After the appearance of the blocking antibody, they may become hypothyroid. So there is a shift from hypothyroidism to hypothyroidism, which correlate with a shift from TSI to TBI. Patients with TBI positivity become hypothyroid, and if you are now relying on the binding TRAB assay, you cannot differentiate this. There is no differentiation. Why? Because the binding assay is always positive. If the sample is TSI positive, the binding assay is positive. If the sample is blocking antibody positive, the binding assay is also positive. So the binding assay is just telling you that this sample contents, or the content of the samples, is antibody, TSH receptor antibody positive. Again, showing you the clear advantage of measuring both TSI and TBI when monitoring the patient. You are on the safe side, the diagnosis and monitoring are more accurate, and this has a great advantage in contrast to measuring the binding assay. Now, we were interested in our laboratory to compare our bioassay to different binding conventional assay. This is one equipment in my laboratory, and this is my technician doing this work every day. And several years ago, we have cooperated with the Mayo Clinic, with Stefan Grebe, and we have compared the sensitivity of the bioassay with a conventional binding assay. this equipment I have shown you in a previous slide. And clearly, as shown in the blue arrow, we are measuring antibody against the TSH receptor at very, very low concentration with the bioassay. And this is not the case with the binding assay. You see that the concentration actually of the antibody is much higher when you are detecting these antibody with the binding assay. So a clear difference of sensitivity between the bioassay and the binding assay. And performing another trial at our institution, again comparing the bioassay and the measurement of TSAb with the binding assay, the THYROID assay, and looking at parameters of analytical performance, limit of detection, limit of quantitation, cutoff level, half maximal effective concentration, EC50. These are typical parameters of analytical performance. We did observe a huge difference of magnitude between the bioassay and the binding assay, the THYROID measurements. Clearly going from differences of 250-fold to 820-fold, huge difference between both assays. And look at 100 patients, well characterized, 100 subjects, and did evaluate the sensitivity and specificity of 7 different assays, 5 binding assays and 2 bioassays. We had 20 healthy controls. We have 60 well-characterized, untreated hypothyroid patients with Graves' hypothyroidism. They were all TSH receptor antibody positive. And we had 20 well-characterized patients with Hashimoto thyroiditis. Hypothyroid patients, all these hypothyroid patients were also TSH receptor antibody positive. So 100 subjects, well-defined, well-characterized. All the healthy controls were devoid of autoimmune disorders, and the family history was negative for autoimmune disease. And look at this. We have been looking at the bioassay with 2 different ELISA readers, just to be on the safe side. All the samples, the 60 samples of patients with Graves' hypothyroidism, were bioassay, 100% bioassay positive with both ELISA reader. Now, if you go to binding assay, these 2 were ELISA, so-called ELISA assay. The Kronos assay is widely distributed in the United States. And the Dynex is also an ELISA assay. These 3 assays are automated assay. This one is from Siemens, the Immolite assay. This one is from the Roche company. And this one is from Thermo Fisher. Now have a look at the sensitivity of the 3 automated assay and the 2 ELISA assay. Only the Kronos one, using a monoclonal stimulatory antibody, is as sensitive in this test as the bioassay. All other binding assay, automated, speedy, automated assays are less sensitive, far less sensitive than the bioassay. If you look at the Cryptor, Thermo Fisher, Cobas, the Dynex. So clearly a difference of sensitivity. Now we went a step further and diluted our samples, different steps, 1 to 3, 1 to 9, 1 to 27, and so on. And compare these 5 assays, the bioassay with the Kronos ELISA, Immolite, Cryptor, Dynex. And after one dilution, 50% of the binding assay are losing their sensitivity. After second dilution, even more than 50% are now not detecting any antibody. And at higher dilution, only the bioassay is still detecting antibodies, showing you the greater sensitivity of the bioassay. And this is the most important message when doing these experiments. We have looked at 20 patients with Hashimoto thyroiditis. All these patients were blocking antibody positive, explaining why these patients were hypothyroid. All these patients with Hashimoto were stimulatory antibody negative. The blocking antibody bioassay, 100% positive with both ELISA reader. And look at this, very impressive results. All 5 binding assays are highly positive, nearly 100% positive for actually these 20 samples, meaning that these binding assays, these 5 assays, are not differentiating between blocking and stimulating antibody. They are just telling you these 20 patients with Hashimoto samples, with Hashimoto thyroiditis, are actually positive in the binding assay, although they are only blocking antibody positive and not stimulatory antibody negative. So to sum up, both stimulatory and blocking antibody bioassay detect TSH receptor antibody at very low concentrations, showing you the high sensitivity of these bioassays. The sample dilution study showed higher detection sensitivity for the stimulatory antibody bioassay. None of the binding assay differentiated between stimulatory and blocking antibody. The stimulatory and blocking bioassay exclusively differentiate between the TSH receptor antibody functionality and demonstrate higher performance than all automated and ELISA binding assay. So you would say, okay, what is the clinical impact of this bioassay? Well, we have several putative advantages over the binding assay. Clearly, we are dealing with actually a better analytical sensitivity with a bioassay. The TSAb and the TSI are analytically more sensitive than all binding assay. We can measure antibodies in patients with subclinical thyroid dysfunction with lower TSH receptor antibody concentration. And this is not the case with the binding assay, because the binding assay requires higher antibody concentration in the serum to detect these antibodies. We can diagnose earlier and treat earlier and manage the patients earlier. The bioassay and the measurement of stimulatory antibody better predicts response to treatment. There is a pregnancy need to know functional type of antibody. This is important. Is the fetus at risk for hyper or hypothyroidism? And TSAb and TSI better correlate with severity of extrathyroidal systemic disease, systemic grave disease. So do we have primary clinical application? Yes, of course. The first one, we can distinguish grave disease from other causes of thyrotoxicosis. We do know that radioisotope scanning is non-diagnostic, and we do know that radioisotope is contraindicated during pregnancy. Second, we can predict and monitor the response to drug therapy in grave disease. Third, we can predict the risk of neonatal grave disease. Fourth, we can confirm diagnosis of Graves' eye disease or systemic disease. So when should we use TSH receptor antibody? Well, to diagnose earlier, to differentiate better, to predict systemic disease, especially with thyroid-stimulating antibody measurement, to monitor antithyroid drug treatment, to monitor fetal complication in pregnancy, to diagnose euthyroid thyroid orbitopathy, to evaluate new drugs in development. All in all, it is an improved physician intervention. I thank you.
Dr. Kahaly, thank you for that informative presentation. A quick reminder to our audience on how to submit questions. Simply type them into the drop-down box located on the far left of your presentation window, labeled Ask a Question, and click the Send button. Dr. Kahaly will answer questions via email only. You may begin sending your questions now. I'd like to thank the audience for joining us today. We would also like to thank our sponsor, Quidel, for underwriting today's educational webcast. This webcast can be viewed on demand. Laboratories will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's event. That's all for now. Thanks for joining us, and we hope to see you next time. Goodbye.